Welcome to this video about recurrent glomerulonephritis post-transplant. In this informative presentation, we'll explore the complexities of this condition, covering its causes, mechanisms, symptoms, diagnosis, treatment, and outlook. Understanding this specific complication after kidney transplantation is crucial for improving patient outcomes and quality of life. Recurrent glomerulonephritis post-transplant occurs when the original kidney disease that caused the need for a transplant reappears in the new kidney. The causes depend largely on the type of glomerulonephritis. For example, IgA nephropathy, a common cause of kidney failure, can recur because the underlying immune system abnormalities that produce the IgA deposits persist. Similarly, membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, FSGS, and other forms of primary glomerulonephritis can recur as well. The precise reasons why these diseases recur are not fully understood, but factors such as persistent circulating antibodies, genetic predisposition, and ongoing immune system dysregulation all play a role. The pathophysiology involves the same disease processes that caused the original kidney failure, now targeting the transplanted kidney. For instance, in recurrent IgA nephropathy, IgA antibodies deposit in the glomeruli, triggering inflammation and damage. In SGS, podocyte injury leads to proteinuria and progressive scarring of the glomeruli. The end result is glomerular damage, proteinuria, declining kidney function, and potentially transplant failure. This damage occurs because the underlying immune or metabolic abnormalities that initially caused the disease continue to affect the glomeruli of the new kidney. Epidemiological data varies based on the specific type of glomerulonephritis. Some types, like membranoproliferative glomerulonephritis, have relatively high recurrence rates, while others, such as lupus nephritis, have lower recurrence rates. It is crucial to understand the pre-transplant diagnosis because this will give doctors an indication of the possible recurrence. Overall, recurrent glomerulonephritis is a significant cause of graft loss, with some studies suggesting it accounts for a notable proportion of transplant failures. The signs and symptoms of recurrent glomerulonephritis are often similar to those of the original disease and can overlap with other causes of kidney dysfunction. Proteinuria, the presence of protein in the urine, is a common early sign. Other symptoms include hematuria, or blood in the urine, edema, or swelling especially in the legs, ankles, and around the eyes, hypertension, or high blood pressure, and a gradual decline in kidney function as measured by increasing serum creatinine levels. Diagnosis typically involves a kidney biopsy. A biopsy allows pathologists to examine the kidney tissue under a microscope to identify the characteristic features of the recurrent glomerulonephritis. This helps differentiate it from other causes of graft dysfunction, such as acute rejection, chronic allograft nephropathy, or drug toxicity. In addition to a biopsy, urine analysis and blood tests are performed to assess proteinuria, hematuria, creatinine levels, and other markers of kidney function. Regular monitoring post-transplant, including blood and urine tests, is critical for early detection. While recurrent glomerulonephritis is broadly classified by the original disease process that recurred, e.g., recurrent FSGS, recurrent IgA nephropathy, there are no specific distinct subtypes of recurrence itself. The clinical presentation and severity can vary depending on factors such as the specific disease, the time elapsed since transplantation, and the individual patient's immune response. Treatment and management strategies aim to slow the progression of the disease and preserve kidney function. Immunosuppressive medications, which are already used to prevent rejection, may be adjusted or supplemented with other agents to target the specific immune pathways involved in the recurrent glomerulonephritis. For example, rituximab, a B-cell depleting agent, may be used for certain antibody-mediated forms. Supportive care, including blood pressure control with ACE inhibitors or ARBs and management of proteinuria with the same medications, is also essential. In some cases, plasmapheresis or intravenous immunoglobulin of IgA may be used to remove harmful antibodies. Dialysis or repeat transplantation may be necessary if kidney function declines significantly. Currently, there are no definitive ways to prevent recurrent glomerulonephritis post-transplant. However, strategies to minimize the risk include careful selection of transplant recipients, preemptive treatment of the underlying disease, and close monitoring of kidney function and proteinuria after transplantation. Research is ongoing to identify biomarkers that can predict recurrence and to develop more targeted therapies. The prognosis for recurrent glomerulonephritis post-transplant varies depending on the type of glomerulonephritis, the severity of the recurrence, and the response to treatment. Some patients experience a slow progression of the disease, while others may have a more rapid decline in kidney function. Recent research is focused on developing more effective immunosuppressive therapies and identifying novel biomarkers that can predict recurrence and guide treatment decisions. New therapies targeting specific immune pathways or inflammatory mediators hold promise for improving outcomes for patients with recurrent glomerulonephritis. Thank you for watching, and we hope this information was valuable.